This is the second presentation about diffuse lung disease prepared by Prof. Sharaf and revised by Prof. Yusriya Sabri. You should specify the pattern you have, whether it is centrilobular, perilymphatic, or random, whether it is upper lobe or lower lobe, whether it is central or peripheral, because this will usually help in diagnosis. We will not go back into these items, but small representation is still there. You can go back to diffuse lung disease presentation 1. Everything is described in details. Centrilobular means around ways, and perilymphatic could be along fissure, could be interlobular, could be intralobular, like this. This is called the perilymphatic. Of course, the sarcoid is a good example for perilymphatic, while infiltration within the lung is centrilobular is good example, is pneumonia and emphysema. Also, emphysema is not considered interstitial disease. So the distribution is very important. We finished the patterns and we discussed reticulation, nodulation, and increased and decreased translucency. Now we are discussing the distribution of these changes. If we have upper preference is seen, think about smoking related respiratory bronchiolitis or inhalation like pneumoconiosis and sarcoidosis, and of course histiocytosis. All these have upper lobe or upper zonal preference. Lower zonal preferences, any aspiration or inhalation like asbestos. Of course, pulmonary edema is more basal than apical, and in addition the usual interstitial pneumonia, or what is called as the interstitial pulmonary fibrosis, usually lower zonal. Centrally and peripherally. Centrally, of course, the best example is pulmonary edema, while peripherally, the peripheral means subpleural. You will go to the two main lesions you know now, the poob, which is bronchiolitis obliterans organizing pneumonia, or now it's called cryptogenic organizing pneumonia, COP, and the other one is the UIP, the usual interstitial pneumonia or the interstitial pulmonary fibrosis. The same, the two are the same. So centrally edema, peripherally is a COP and UP, or BOOP and UIP. Both of these result in peripheral distribution of the reticulations, of the nodulations, and of the emphysematous changes. Another review, the reticular airspace at the mid and lower zonal, peripheral, subpleural changes that you have now combined two things. We combined being peripheral and we combined being basal. So mid and lower zonal, peripheral, subpleural changes, as we said, UIP and BOOP. Here are we cannot include cannot include RP, smoking related, pneumoconiosis, histiocytosis, sarcoidosis, because all of these are upper lobar, and we are now talking about lower lobar, like inhalation, asbestos, pulmonary edema, UIP, etc. In order not to repeat again, we are now discussing central and peripheral, central as pulmonary edema, peripheral as BOOP and UIP, and then we combine both periphery and lower zonal. So we are now talking about UIP again and BOOP, and UIP, as I said before, is interstitial pulmonary fibrosis or usual interstitial pneumonia. They are the same. This of the unknown group. The known group, inhalation, of course, asbestos is basal. Asbestos is subpleural because it forms plaques, pleural plaques, and drugs are mainly down. Lymphangitis, if it is central, it will affect the periphery as well. And PCP, viral and mycoplasma and heart failure acute condition are mainly mid-zonal and basal, as in bat swing edema or butterfly edema. They are sparing the APCs. In connective tissue group, interstitial lung disease in connective tissue or vascular, like rheumatoid, systemic, and amyloidosis, all are related to the periphery and related to the basal, mid, and lower zones. Additional findings, you might find it: pleural fluid, lymphadenopathy, bronchiectasis, and you should know why bronchiectasis occur, because of traction due to reticulation and fibrosis. So we can have pleural fluid, that is transudation of fluid, and lymphadenopathy means that the lymph nodes are enlarged, and the bronchiectasis is due to traction. I think now you are getting the idea that the interstitial is land of lymphatics. The land of lymphatics. If you obstruct, you will get fluid. If you infect, you get lymph nodes. And if you fibrose, you get bronchiectasis. When to see pleural effusion? So simple that if you have a patient with pulmonary edema, it will be resolved once effusion starts to occur. Lymphangitis spread of carcinoma, but this is often unilateral. In TB, you can find tuberculous pleurisy, tuberculous empyema. In lymphangiomyomatosis, LAM, you can find sometimes. In asbestosis, of course, we are dealing with the periphery, so expect that the periphery can have some sympathy, and you will find pleural effusion. When to get hilar and mediastinal lymphadenopathy is the same we are talking about in pneumoconiosis, sarcoid, of course, and lymphangitis. Anything that irritate or grow inside the lymph node will cause lymphadenopathy. In sarcoid, there is giant cells growing inside, and in carcinoma there are malignant cells growing inside. The same with lymphangitis carcinomatosa, which is due to malignant obstruction of the lymph nodes. And the eggshell calcification can occur, of course, in pneumoconiosis, especially silicosis. So, but sometimes you can see eggshell calcification in sarcoid. It's the differential of hilar and mediastinal lymphadenopathy in interstitial diseases. The main diseases we are talking about here is sarcoid, carcinoma, lymphangitis carcinomatosa, and pneumoconiosis. Interstitial lung diseases classification. If we remember that we have those of unknown etiology and those of known etiology, and then ILDs and CTDs. To make it more clear, those of unknown etiologies are the interstitial pneumonias. Those of known etiology are due to granuloma or drug or hypersensitivity, and those with CTDs like rheumatoid scleroderma and so on. The pattern of such, the whole thing, we now know about reticulation, nodulation, ground glass, cystic changes, and emphysema. Make this as your key point in describing or reporting any of the interstitial lung disease. Describe where are the reticulations, their distribution, whether centrally lobular or interlobular, intralobular, bronchovascular, nodules the same, whether along lymphatics or centrally lobular, ground glass appearance, whether it is inside the lobule or in bud, tree in bud appearance, cystic changes which can occur sometimes as due to traction, and emphysema which can occur as an association as in lymphangitis, as in lymphangiomyomatosis. So these are the pattern you should describe, and this is the distribution you should describe. If it is centrally lobular, means at the center of the lung, perilymphatic or random, and describe if it is upper zonal, lower zonal, central, or peripheral, and put the additional findings as pleural fluid lymphadenopathy and the presence or absence of traction bronchitis. We will discuss now the interstitial lung diseases itself, which are known as the diffuse parenchymal lung diseases. Major interstitial lung disease of unknown etiology. We have two major types: sarcoid, and on the other hand, interstitial idiopathic pneumonias or idiopathic interstitial pneumonias. Sarcoid, you know about very well, with the bilateral hilar lymph nodes, if nodal, or bilateral patches or nodulations accordingly. And then the second thing is the idiopathic interstitial pneumonias, the IIP. So the IIP is one of the major unknown of the major interstitial lung disease of unknown etiology. And we have mainly 6 types. The IPF, you know very well about it. IPF is the idiopathic pulmonary fibrosis. The other name is the usual interstitial pneumonia, and these are 50% of all disease, of all idiopathic interstitial pneumonias. This is 55%. There was a term called cryptogenic fibrosing alveolitis, no longer used now. So the first item in the idiopathic interstitial pneumonias is the idiopathic pulmonary fibrosis, or the UIP, and don't use fibrosing cryptogenic or fibrosing alveolitis. And this forms 55% of all interstitial pneumonias. The second is the non-specific interstitial pneumonia, which is about 25%. Then smoker-related, we have 2. Respiratory bronchiolitis, 10%. Desquamative pneumonia 5%, or the DIP. And then the cryptogenic organizing pneumonia, there is something else. Cryptogenic organizing pneumonia is the COP or POOP, and this forms 3%. Then acute interstitial pneumonia, then the lymphoid interstitial pneumonia or the LIP. It is the rarest one. These are the 6 groups. Then we have the major interstitial lung disease of the known etiology, and this forms 35% of all interstitial lung diseases, including pneumoconiosis, extrinsic allergic alveolitis, drugs and radiation, and post-infection. Usually these are acute viral BCP and mycoplasma. These are representative of the acute form. All these groups have known etiologies, and they form 35%. The third is the presence of interstitial lung disease in connective tissue diseases or collagen vascular, including rheumatoid, systemic sclerosis, and in these two mainly because getting it from the name collagen vascular, so you will get vasculitis. You will get pathologically vasculitis. We'll discuss in more details what are the idiopathic interstitial pneumonias. Now we have 6 types. Usual interstitial pneumonia, or the UIP. The other name is idiopathic pulmonary fibrosis. Usually it is basal predominant reticulations. You consider this only. Please don't diagnose anything except this, because this one is 55% of all interstitial lung pneumonias, idiopathic interstitial pneumonias, the IIP. This one is 55%. So if you consider, if it is basal and peripheral, put the diagnosis of IPF or idiopathic pulmonary fibrosis as soon as possible. You consider this. The second one is the non-specific interstitial pneumonia, which is mainly fibrotic. And if we go back again here, the non-specific interstitial pneumonias forms 25%. And it's mainly again seen as bi-basal ground glass. So your job is finished. 80% of the idiopathic interstitial pneumonias is basal and peripheral. It is either predominant reticulations in 55%, and this is called interstitial pulmonary fibrosis, or it is bi-basal ground glass, and this is called the non-specific interstitial pneumonias. So you are in between these two. Either you find predominant reticulations basally and peripheral, go ahead and put idiopathic pulmonary fibrosis, IPF, as your diagnosis. And of course you should know the synonym, the UIP, or the usual interstitial pneumonitis. If not, and there are some ground glass appearance at the basal region, go and diagnose NSIP, or the non-specific interstitial pneumonia, which forms 25% of the conditions. The third one is the cryptogenic organizing pneumonias, or the COP, or the POOP, bilateral peripheral consolidation, so you cannot differentiate. While respiratory bronchiolitis and squamative interstitial pneumonias deep are seen in smokers, there should be smoker, and are seen as bronchial wall thickening, air trapping, and is associated predominant upper lobe and central ground glass opacities. Upper lobe. This group is associated with predominant upper lobe. So now if you get bilateral basal reticulations, you are dealing with IPF. If you get bilateral basal patchy consolidation, you are dealing with NSIP, or the non-specific. If you are getting upper lobe predominant ground glass, you are dealing with, and there is history of smoking, you are dealing with respiratory bronchiolitis. And this forms 10%. So we have bilateral basal reticulations 55%, idiopathic pulmonary fibrosis. You have 25% non-specific interstitial pneumonias seen as patchy bibasal ground glass appearance, and this is 25%. You have smoker-related. The first fulfillment should be that the patient is smoker and upper lobe desquamative and respiratory bronchitis, both follows 15%. So we talked about the BOOP, and as bilateral peripheral consolidation, you cannot discriminate it from the non-specific type, and this forms 3%. This is the microscopic diagnosis. And for respiratory bronchiolitis and deep, you should have a patient with history of smoker, as a smoker, and this is usually predominant upper lobe and central ground glass opacities. Still we have the acute interstitial. This is very rare, and it means acute respiratory distress syndrome. Ground glass consolidations develop in days and progress to fibrosis, and usually there are history of ICU admission or something like that. Acute interstitial pneumonia is not away from ARDS. It is rare. Lymphatic or lymphocytic interstitial pneumonia, or LIP, is uncommon and usually in patients with AIDS. Lymphocytic or lymphatic interstitial pneumonitis is rare and no more than 1%, something like that. So you are left with these two groups. Either you are dealing with bilateral basal reticulation, and you know now the IPF, or you are dealing with bilateral or bibasal ground glass appearance, and you are dealing with non-specific interstitial pneumonia. Please consider the first one in most of your work. The diagnosis, pathological diagnosis, is usually a microscopic. The diagnosis is usually a pathological diagnosis for the rest, and for these two also. In conclusion, bilateral basal or peripheral reticular ground glass nodular cystic emphysematous are diagnostic of usual interstitial pneumonitis, UIP, or idiopathic pulmonary fibrosis, and you can use on any of these terms, either or. Either you can say UIP or you can say IPF, and this forms 55% of all patients. The rest should be pathologically proven. As NSIB is 25% but need pathology, COP needs pathology, and And number 4 is a deep and the respiratory bronchiolitis needs to be a smoker. Number 5, the acute interstitial type needs to have ARDS, ICU patient. And number 6 is usually related to AIDS. Interstitial pneumonias means involvement of the parenchyma. That means the whole unit by inflammation and fibrosis. Idiopathic interstitial fibrosis are responses and do not represent diseases. Although idiopathic, yet the same patterns are seen in those group of diseases with known etiology, as collagen vascular diseases, scleroderma, or known etiology like drug-related disease. So scleroderma and rheumatoid arthritis are representative of those with known etiology due to collagen disease or vascular disease, and here it is the vasculitis, while then those, for example, of drug-related and hypersensitivity reaction are due to known etiology, irradiation, drug-related, something like that. The group we want to concentrate upon is the idiopathic interstitial pneumonias as part of interstitial lung disease of unknown etiology. Number 1 is the sarcoid, number 2 is this group, the idiopathic interstitial pneumonias. I think now it is clear. Now we get the word vasculitis because we said about those of known etiology as in collagen vascular diseases and in connective tissue disease. And we said that the main pathology in such cases is vasculitis. What is the groups you know about? What is the classification of vasculitis? If the vessel is big, it is called Takayasu or giant cell temporal arthritis, as in the old age. If it is medium sized, it will incide the brain. It is polyarthritis nodosa or Kawasaki. If it is a small vessel, it is a microscopic polyangiitis or Wegener granulomatosis or Churg-Strauss syndrome. If it is immune response, the famous is the Henoch-Schönlein Berbera and Bassett disease. So I think this makes vasculitis somewhat clear. The radiologic manifestations of primary pulmonary vasculitis include vessel wall thickening, nodular or cavitary lesions, ground glass in the lung. We are talking about in the lung. Vessel thickening, nodular or cavitary lesions, ground glass opacities, consolidations, and sometimes DAH. And this is most important. DAH is the diffuse alveolar hemorrhage. This occurs in primary pulmonary small vessel vasculitis. Primary pulmonary small vessel vasculitis. You can get this name. This term or this name, primary pulmonary small vessel vasculitis, could be due to Wegener, Churg-Strauss syndrome, and polyangiitis. These three can result in DAH or the diffuse alveolar hemorrhage, besides the changes as vessel thickening, nodulations, cavitation, ground glass appearance, non-specific things like that. So this is the first thing. What is the Churg-Strauss vasculitis? It is a triad of rhinitis and asthma, eosinophilic pneumonia, and systemic vessel vasculitis. triad of allergic rhinitis and asthma, eosinophilic pneumonia and gastroenteritis, and systemic small vessel vasculitis with granulomatous inflammation. What are the other causes of diffuse alveolar hemorrhage? Number one, we have this group: the primary pulmonary small vessel vasculitis, including Wegener, Church-Strauss, and polyangiitis. Number two, idiopathic. Number three, drug reaction. Number four, anticoagulation disorders. Thank you.